life-threatening. Then check the pH. Then don't forget to put topical anesthesia and put a speculum so you can irrigate the eye. And there are so many different ways of irrigating the eye as seen here in these diagrams. But if you don't put topical anesthesia and the patient is squeezing, then nothing is going inside the eye and then the patient is not being irrigated. Then check if you can and remove any debris, because if there are any debris, they will continue to produce the chemicals. And then after doing all that, you have to recheck the pH again after 10 minutes, because even if the pH is neutralized, it can change again in 10 minutes. The best is the diphoterin, which is an amphoteric chelating agent which binds to both acids and alkalis, and you only need 500 milli of these diphoteric solutions. The advantage of diphoteric solution is that it can chelate the acids or alkalis out of the cells, not only wash them. Then if you've done your irrigation and you still the pH is not neutralized, you can do actually a paracentesis to add another 1.5 units of reduction in the pH, or you can inject buffer phosphate solution into the AC. Then once you've done the initial wash, you need to assess and grade the lids, the cornea, the limbus, and the conjunctiva. Very important to have a properly maintained ocular surface. And this patient, for example, you have to do multiple lid procedures before managing the ocular surface. Otherwise, whatever you do on the cornea and ocular surface will not work. Then after you've done that, then you have to classify the burn. You need the classification because it's very, very good prognostic technique. The Roper Hall is the initial classification based on the limbal ischemia and the amount of visualization of the iris vessels. But now we've got the DUAS classification, which is much better prognostic classification than the Roper Hall, because there is the concept of the use of the conjunctiva to maintain the ocular surface. For example, the drawback of the Roper Hall is that you cannot cross overlap between the different grades, and also it was established before the concept of stem cell transplantation has been there. For example, this is an example of Roper Hall grade 4, another example of Roper Hall grade 4, and you can see clearly the prognosis of the two different cases are not the same. So that's why you need the DUAS classification. Once you've assessed the ocular surface, you have to assess the rest of the eye, the iris, the pupil, the lens, and don't forget the pressure. And sometimes you can't measure the pressure. You need the tonopen because of the surface is irregular. And even if sometimes with a lot of lid problems, then you have to also rely on your digital palpation. We've lost so many patients with chemical burn due to pressure than ocular surface. So you spend so much time trying to reconstruct the ocular surface and you forget about the pressure, and the patient ends up losing vision from glaucoma. So remember to check the pressure. Now, once you've done that, you need to control the inflammation. You remember you can use the steroids preservative-free in the first 6 days and after 4 weeks, because that's the time where it does not enhance collagenase activity. You need your antiproteases. The sodium citrate is very important. We give it hourly in the first week or so, and also oral tetracyclines to prevent melting. Ascorbates are very, very painful to put, so we don't use drops of ascorbate, but we use oral ascorbates up to 2 to 4 grams per day. And you need the ascorbate, otherwise the collagen synthesis does not happen, because the ascorbate level goes very low in the stroma with chemical burn. So that's why you need your oral ascorbates. Then you have to facilitate wound healing by artificial tears, autologous serum, and other growth factors. Don't forget to use broad spectrum antibiotics. We use it preservative free 4 times a day. And if you're using Midriatex or cycloplegic, don't use phenylephrine, because it will increase your limbal ischemia. Remember to use anti-glaucomas, and with the anti-glaucomas, avoid adrenergic agonists such as brimonidine, because they will not cause collagen shrinkage, and they can affect the uveoscleral outflow. So when do you use surgery in the acute stage? As Professor Dua has said, we can use sequential sector conjunctival epitheliotomy if you have an area of surviving limbus, because you want the cells to go from the surviving limbus and not from the conjunctiva. That's only if you have a surviving limbus. But when do we not use, and this is how to show that the patient eventually settles down with only conjunctival visualization outside the pupillary area. But when do we not use SSCE in acute stage? If you have a patient like this with no surviving limbus, then you want any conjunctival epithelium to go on top of the cornea. So you don't do SSCE and allow the conjunctival epithelium to grow on the cornea, because any epithelium is better than no epithelium. And that is an example of the patients where the conjunctival epithelium has gone completely, and sometimes conjunctival epithelium can redifferentiate into corneal epithelium, and we've seen that happen, and the cornea clears. Also in acute stage, you can use an amniotic membrane. There's Omni lenses or the Porchera, which are available. And if you have a patient in a high dependence unit like this patient, you can use the dried amniogen or the frozen amniogen, or one of the ones that are available off the shelves, and you use hooks, and you can put once you put the amnion, you can put some fluids to make it soft, and then it's very important to put a conformer so that the lids don't stick together, and you don't get a symblificon, because managing the ocular surface becomes much more difficult if you have symbliferon. If the amnion doesn't work, like in this patient, you can take an autoconj graft from the other eye if it's a unilateral case, and we have seen that this has worked very well to reconstruct the ocular surface. So remember, in acute stage management, your first stage measurement, wash, 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 then pH. Prevent any further damage, and assess and grade so you know your prognosis and you can tell your patients. Control the inflammation and facilitate healing by lubricants and other growth factors, and surgery has some role in the acute stage. Thank you.